Pursuant to Standing Order 1082 and the motion adopted on Tuesday, February 1st, the committee will resume its study on mental health of young women and girls. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2002. Members are attending in person in the room and remotely using the Zoom application. I would like to make a few comments for the benefit of the witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raise hand function. The clerk and I will manage the speaking order as best as we can and appreciate your patience and understanding in this regard. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection test in advance of the meeting. And as we have noted, anybody who is participating in the meeting must have one of the headsets. So thank you so much. We are also doing a very difficult study, so I'm just going to remind everybody, before we welcome our witnesses, I would like to provide this trigger warning. This will be a difficult study. We will be discussing experiences related to mental health. This may be triggering to viewers, members, or staff with similar experiences. If you feel distressed or if you need help, please advise the clerk. I would now like to welcome our witnesses for today, and everybody is on Zoom for today. So from Achev, Karen McNeil, who is the Senior Vice President, Programs and Services. Tanea Armoral from Director, Women, Employment and Newcomer Services. As an individual today, we have Dr. Rakesh Jetley, who is a psychiatrist. From the Northern Ontario School of Medicine University, Dr. Diane Whitney, Assistant Dean, Residence Affairs. And Dr. Peter Ajus, and you can help me with that last name after, who is the Assistant Professor and General Child and Adolescent Psychiatrist, Health Services of North Sudbury. Regroupement des Ressources Alternatives et Santé Mentale du Québec. And from that organization, we have Anne-Marie Boucher, Coordinator and Head Communications and Social Political Action. So for each group, we'll be providing you 5 minutes for your opening comments. I'll be interrupting usually within the first few seconds if it's quite overboard, and we will be doing our rounds. I'm just going to let you know today, as I know we did start late, we will be extending a little bit, but we'll kind of be playing it by ear as a committee as we're going through. So I hope that some of you will be able to stay on with us a little bit after 5:30 as well. So thank you so much. I'm now going to turn it over to Karen and Tanya. I'm going to provide you 5 minutes for your organization to do your opening remarks. The floor is yours.
Thank you. Good afternoon. Thank you for the opportunity to speak today. My name is Karen McNeil, and I'm the Senior Vice President of Programs and Services at Achieve. I'm joined by my colleague Tanya Merrill, who is the Director of Women, Employment and Newcomer Services and has some intimate program knowledge. For more than 30 years, Achieve has provided free services to Canadians and newcomers to Canada. Today, we're one of the largest nonprofit providers of employment, newcomer, language, youth, and women's services across the GTA, with programming across Canada. Each year, more than 50,000 women and girls access Achieve's services in person, virtually, or through a hybrid format. Our approach recognizes the unique barriers women face in securing employment, settling in a new community, and building the networks they need to thrive. Today, we'd like to speak about immigrant women and girls, who represent almost half of our women clients. It's estimated that by 2031, 1/3 of the Canadian female population will be immigrants. We know that immigrant and racialized women in Canada face numerous barriers to meaningful employment. These barriers have been exacerbated by the pandemic and include a lack of work-related networks, family caregiving responsibilities, sometimes language barriers, and gendered or racial discrimination. Even when women immigrants are employed, they're more likely to be underemployed, work part-time, or in precarious employment situations and be poorly paid compared to their Canadian-born counterparts. This has a significant impact on these women's everyday lives and their mental health. Our clients experience many challenges when they move to Canada. Newcomer women in particular often face multiple stressors on their mental health and well-being. They often have primary responsibility for establishing a new home, getting their kids into school, caring for elderly parents, and finding a job. It's really not easy. Many are socially and linguistically isolated and lack self-esteem and financial security. We've also seen the unique struggles that international students are facing. These include young women living far from home, some with enormous pressure to succeed, facing loneliness and limited financial resources and supports. Every woman brings her own story of her personal struggle, and I'd like to share one with you today. Priya is a single mother. She obtained a master's degree in economics from her home country, but was working as a cashier at Walmart. Priya was stressed, tired, and worried about how she would be able to handle her life and parenting. She couldn't leave her survival job because that was the only source of income for her family. She was heavily depressed due to this dilemma. Her employment coach at Achieve was able to share a lot of resources and connect her with a women's wellness program offered by a community partner. This enabled Priya to receive the support needed to improve her well-being and successfully secure a new, better-paying job where she felt respected. One of the biggest issues we've seen in addressing the mental health needs of newcomer women and girls is the stigma around mental illness in their communities. In some cultures, mental health-related issues are highly stigmatized. As a result, sometimes it's difficult for them to acknowledge that they're dealing with mental disorders and should seek help. This leads to longer-term suffering. We've heard from some young women that even when they've gathered the courage to tell their parents that they're struggling mentally and need help, they often don't know where to turn. This is why we believe that integrating more mental health supports into newcomer, settlement, language, and employment programs are critical to address the stigma and provide culturally appropriate intervention. More awareness of mental health within our newcomer communities will help women and girls access the supports they need, bridge the generational gap, and encourage family conversations. We're proud of the mental health wraparound support that we're able to provide women in some of our programs, including inviting mental health service providers into our workshop sessions, incorporating self-care practices into programs, and sharing open resources. But these programs are not enough. We recommend more multi-year government-funded opportunities for community-based organizations like Achieve to include these wraparound supports for every woman or girl who needs them. We've seen firsthand the power that sharing real lived experiences and creating safe spaces to discuss mental health has had on the betterment of our newcomer women clients. Thank you for the opportunity to share our insights today, and we look forward to answering any questions you might have.
Thank you very much. I'm now going to turn the floor over for 5 minutes to Dr. Jetley. Dr. Jetley, you have the floor.
Thank you, Madam Chair. In my opening comments, I would like to share my thoughts on several topics, including mood anxiety difficulties in girls and young women, the challenges of being a young woman today, a little about substance use, as well as my concerns regarding psychiatric research and knowledge translation. Many have discussed the epidemic of mood and anxiety, particularly in young people, attributed to the COVID-19 pandemic. However, as a psychiatrist, and some of the testimony you've already heard, I feel that youth mental health has been a significant issue for many years. Several times a month, a colleague reaches out, invariably for help because of mental health needs within the family. I noticed very quickly that over 90% of the time, it's a daughter or a niece with anxiety difficulties. This is not a study, but rather my own experience, and it is particularly concerning when a 16-year-old often faces an 18-month wait to see a psychiatrist. Recently, I've been asked to help care for a young woman sexually assaulted after being slipped to hypnotic during a university social event. There's an interesting double-edged aspect regarding psychological difficulties in young people. Never have we had a generation with such positive attitudes towards mental health and help seeking. Our generation struggled with stigma, and programs such as the military's Road to Mental Readiness and Bell's Let's Talk help stigmatize and to some extent normalize mental health and help seeking. This generation of young people does not need encouragement to talk. They have spoken and feel much less shame when raising their hand. While this is encouraging this is an encouraging societal trend, it results in an even greater need, overwhelming the system and worsening the need care gap. Vast numbers of young women and girls acknowledge not feeling right, but are unable to have timely access to evidence-based care. My second general observation is the amplification of peer pressure, bullying, etc., that social media allows. There are undeniable pluses to social media platforms that allowed us to stay connected, celebrate birthdays, and even attend funerals during the lockdowns and the pandemic. However, there are also studies suggesting that in some young women and girls, social media can make individuals feel more isolated and exacerbate mental health conditions such as depression and anxiety. There is a suggestion that some aspects of social media may increase the sense of inadequacy about one's life or appearance. Online bullying also to some extent is traditional bullying on steroids. Depending on the study one reads, about 40% of young people under 19 years report being victim of bullying online. Interestingly, girls are most likely in most studies to be both victim and perpetrator of cyberbullying. Victims of cyberbullying are at increased risk of both self-harm and suicidal behaviors. Most that witness cyberbullying do not intervene, and perhaps only 1 in 10 report the bullying to a trusted adult. I also wish to switch and just briefly address recreational and social use of substances. Clearly, the opiate crisis warrants attention and young people are not spared. However, we also need to address the most common substances abused by young women and girls, namely alcohol, cannabis, and tobacco. We can educate regarding alcohol's potential harms, but it may also help women to understand how we can separate having a drink with friends celebrating a birthday from drinking alone and feeling sad, lonely, or anxious. The effects of alcohol on cognition, consent, and capacity must also be ingrained. As a society, Canada has done a great job educating our youth about the risks and harms of tobacco, and the consistent downwards trend of smoking tobacco continues in our youth, including girls. However, cannabis use in young Canadians finds our youth as typically, depending on the study again, as number 1, 2, or 3 consumers in the world. While decriminalization, legalization, medical use of cannabis increases worldwide, we require study with respect to the health of girls and young women. There are many active ingredients within cannabis, some which can aggravate mood, anxiety, and even cause psychosis. We have learned some important lessons from smoking tobacco and its impact on one's health, respiratory and otherwise. However, according to some sources, about half of the cannabis used in Canada is smoked. There is confusion and blurring between medical use and recreational use. I will not discuss the limited evidence supporting the medical use of cannabis, although encourage the ongoing high-quality studies that need to be done. I do, however, feel that recreational medical use of the same substance creates an attitude that sometimes this naturally occurring plant is either good for you or at least not harmful. My final point is
Mr. Jetley, Dr. Jetley, I'm going to give you about 20 more seconds to finish. I know you have a few more paragraphs.
Problem.
Go for it.
No problem. My last point really is research specifically looking at women and young girls. Quite often I've sat at the table myself. Sometimes it's complicated because of biological differences in men and women. We've often stuck to right-handed males that are relatively healthy, and then we're forced to knowledge translate that to women. So there's some concerns about studies that even if we ask the gender, do we actually analyze the studies based on gender? And we use excuses like sample size are too small. So I'll stop there. Thank you.
Thank you so much. I do really appreciate that. I now will move it over to the Northern Ontario School of Medicine and Dr. Diane Whitney and Dr. Ed Juzy, and I'll pass it over to you. I share the minutes, 5 minutes.
Okay, so I'll start by saying that I'm a community-based psychiatrist in Thunder Bay, and I treat depression, anxiety, and trauma. In my practice, it's 80% women, and my colleague is a child psychiatrist in Sudbury. So we bring some different perspectives. But first of all, starting talking about the North, individuals in Northern Ontario typically have poorer mental health than in urban areas and higher rates of depression. Twice the rate of hospitalization, usually for suicide concerns, and a very fragmented mental health system if there is one. I'm always amazed how far my patients will travel to get care. It's changed somewhat with COVID, but hasn't cured everything. But I have a lady who comes from a small reserve or takes either a boat or a skidoo to the train, depending on which season it is, to the train, which is often 6 to 10 hours late, and then to a van to get into Thunder Bay. So things have improved for her with different accesses with COVID, but not all the remote communities have an internet access. So if we move specifically to women, certainly intimate partner violence is a significant issue and a higher rate in northern communities and smaller communities, and issues about transportation, emergency housing. And the lady I just mentioned, she was assaulted by her partner who was intoxicated, and she held him down until he passed out. And it took 5 days for the police to get to the reserve to take the report. 5 days. It's a small isolated community of 30 people, just so you know. Experience of violence and abuse, there's a high rate of trauma in the population in general, but in the north it's estimated to be 78% have a history of child and or adulthood trauma, and 16% develop PTSD, leading to suicides and self-harm behavior. We could talk hours on that. And high rates of depression in our Indigenous population, with much higher rates of psychological distress and suicidal ideation and suicide attempts compared to men. And finally, then there's the impact of COVID. There's been some benefits, but apologize for the following background. Some benefits, but certainly I think there's been disadvantages and disconnection as well. One of my patients who I see remotely through what's called the Ontario Televideo Network, what happened in the community was the office where she was using that to see me virtually was taken over as a COVID testing center. And then I had to revert to phone. So the challenges have been many, and I'm going to turn over to my colleague. He's got a few comments about eating disorders, which is a challenge to treat in the north, and I'll turn it over to him.
Yeah, thank you, Dr. Whitney, Ms. Chair. So I've been the consulting psychiatrist to the eating disorder program in the north for the past 10 years when I immigrated to Canada from Republic of Ireland. And the 4 key points I wanted to just bring up to the committee is the increasing number of hospitalizations that we've seen in the north, specifically around eating disorders. Secondly, we have absolutely no inpatient eating disorder treatment facility in Northern Ontario. Thirdly, increasing comorbidities and mortalities with regards to eating disorder. And fourthly, the lack of adequate training of healthcare professionals in eating disorder. And just to briefly give a specific case of a patient that I had who had a BMI of less than 10. And just to give context, so BMI stands for body mass index for those who may not be familiar with it. And the typical BMI is between 18.5. That's the normal BMI between 18.5 and 25. For extreme anorexia, we're talking about a BMI less than 15. This young lady had a BMI less than 10, almost not compatible with life. And for such a person, you would think that it's going to be an emergency and referring down south, but because of lack of available bed, there was no bed anywhere, irrespective of the fact that her BMI was less than 10. She ended up in the ICU twice with what we call refeeding syndrome, almost died. Luckily, we were able to keep her in hospital. She stayed in hospital for up to 6 to 8 months, but luckily she recovered. We currently, since COVID, we're getting increasing number. Again, give another context. From 2018, the number of hospitalization of females between 18 and 17 was about 1%. During the peak of COVID in 2021, it rose to 3.2. And as we speak now, as of July, the percent was it's gone up to 4.3%. We're having people wait to be transferred to the United States. So I'm going to stop at this point because I know we have, and I know there are going to be probably a lot of questions with regards to eating disorder. But thank you. And I also see that during the course of my research that there's been a big focus on eating disorder in the past from this committee. But thank you for this opportunity.
Thank you very much. And for our last witnesses, I'm going to turn the floor over to Anne-Marie Boucher. Anne-Marie, you have the floor for 5 minutes.
Bonjour.
Hello. Thank you for hearing me today on this study. The Regroupement des ressources alternatives en santé mentale du Québec represents about 100 community groups in Quebec. These groups are autonomous in the realization of their mission, which has allowed them during the pandemic to adjust quickly and to efficiently to circumstances and to offer quality support. Our historical underfunding is proven and limits us more and more in the recruitment and retention of personnel, threatening the realization of our missions. Note that several of our groups are developing projects that target young adults. I would now like to share some concerns about the mental health of girls and young women who are even more likely to experience violence, to suffer abuse in a family context, to find themselves in a position of economic dependence. Talking about the mental health of girls and women also means looking at the living conditions of these people with a view to realizing the right to enjoy the best possible mental and physical health, which implies fighting poverty, preventing violence, as much as providing access to a diversity of mental health resources and services. In the context of the pandemic, isolation, upheaval in the educational or work environment, family conflicts, and insecurity have aggravated the psychological distress of many people. A study conducted in the summer of 2020 by the Université de Sherbrooke showed that teenagers, both girls and boys, were experiencing twice as much severe psychological distress as before the pandemic. In the survey on the psychological health of 12 to 25-year-olds published in March 2022, we learned that a quarter of young people attending a secondary vocational school perceive their mental health as fair or poor. This proportion is even higher in higher education. There is also a considerable variability by gender, with girls and those who identify as neither a girl or boy being much more likely to report poor mental health. It is increasingly difficult to have access to public mental health services. Numerous testimonies that we receive and multiple journalistic investigations reveal that even in urgent crisis situations, young and not so young people struggle to have quick access to support. In this context, doctors have no other choice than to resort to medication in order to act on the symptoms of suffering. Since the pandemic, there has also been an increase of the use of psychotropic medications, particularly among young girls. In March 2021, in an article in Le Devoir referring to data from the Régie de l'Assurance Maladie du Québec, we learned that the use of antidepressants has hit girls under 18 years of age particularly hard, with the number of users jumping by 15% since the start of the school year. We learned that by September 2020, they were already 11% more likely to receive these psychoactive medications than at the same time in 2019. Same thing for ADHD. In Quebec, which is the province with the most prescriptions written, according to a report. For both ADHD and depression, mental health experts are concerned about the increasing use of psychotropic medication. The Mouvement Jeunes et Santé Mentale, to name but one citizen movement, has been calling since 2016 for a parliamentary committee to be held to examine the medicalization of the difficulties experienced by young people and for psychological services to be made accessible. The latter demand also being put forward by the Force Jeunesse organization, which this summer unveiled a study arguing in this direction. There needs to be upstream help in terms of living conditions. Some avenues for action and reflection. Ensure vigilance regarding the issue of medicalization of distress in the face of a health crisis or the impacts of violence experienced. For example, it has been documented that a large number of young women diagnosed with borderline personality disorder have experienced sexual abuse or violence. According to an English study, with the same symptoms, women are 7 times more likely to be diagnosed with borderline personality disorder than men. It is important to note that 81% of people diagnosed with BPD have revealed traumas in their lives. The diagnosis is double-edged. It can be the gateway to services, but it can also be the source of stigmatization, and it can distract from the difficulties or traumas experienced and focus solely on the symptoms. Access to services without the need for a diagnosis and the implementation of trauma-sensitive approaches are urgent steps. Providing alternatives to medication and support for reduction and withdrawal are important as well. There should be support for mental health deprescribing, including support for antidepressant withdrawal. In England, there are many initiatives underway to better document the effects of withdrawal from psychotropic medications, notably by the Public Health England and the All-Party Parliamentary Group for Prescribed Drug Dependence, with a view to examining the effects of the recourse to medication without the implementation of follow-up and support for withdrawal. Canada could learn from these approaches. Lastly, we see the importance of increasing health transfers for provinces.
Anne-Marie, 15 more seconds. I'll give you 15 more seconds. Okay?
We see the importance of increasing these federal transfers unconditionally and this would allow provinces to act quickly on mental health. Currently, there's an access crisis, and it is important to act and to fight against poverty and housing and other things as well.
I'm just going to let all the members of the committee know, looking at the fact that we have had a time change, we are going to take our committee business that we were supposed to have today and postpone that till Monday so that we can have our time with our witnesses instead. So on our first round, we'll be starting with 6 minutes, and I'll pass the floor over to Michelle Ferry for 6 minutes.
Thank you, Madam Chair, and thank you to all of our witnesses. Powerful testimony as we delve into this study looking at mental health in young women and how do we close these gaps. Very nice to see my friend Dr. Rakesh Jetley here as a witness. Rakesh, great to see you here. I know you have a wealth of knowledge that can really help this committee and help the federal government make better policy decisions to help our youth and mental health. My question to you, and you've talked about this and you addressed it in your testimony, Dr. Jetley, is we have this great movement where our youth are more comfortable asking for help. They've sort of, the stigma, we've done a lot of work and it's paid off, but when they go to get help, there's nothing there. The resources aren't there. What's your suggestion on how we close the health equity gap?
Well, thank you very much for the question. It's a huge question. My colleague just mentioned what is not the answer, which is to continue to prescribe medication without psychotherapy, without counseling, and let's just give these kids some stimulants and antidepressants. That's probably not the answer. I think realistically, we have to reconsider how we provide care. And that's something that we've struggled with over the years. The idea that every single person that has a psychological difficulties or difficulty fitting in is going to have access to a one-on-one psychotherapy once a week for 1 hour for 6 months, 8 months probably isn't realistic, even if we resort it. So I think leveraging technology is one of the ways to do it. I think developing group-based therapies. There's different kind of platforms that have been developed, like for cognitive behavioral therapy for insomnia, where one clinician can be magnified and see 12 people a week instead of 12 people an hour, instead of that. So I believe it's multimodal. I think it's education. I think there'll be resources in more programs. I mean, clearly the very, very ill, the eating disorders are going to need sort of hospital beds and things. But I think that general wave of mood and anxiety that we're seeing, people are going into walk-in clinics or seeing their family doctors, they're getting prescribed meds and not really getting help. So, it's not a great answer, but I think that we really need to rethink about how we structure access and really get away from the traditional model of this one-on-one psychotherapy for everybody.
Thank you for that, Dr. Jetley. And I think, we know we have a labor crisis across this country, and frontline workers, yourself, psychiatrists, psychotherapists, counselors, doctors, they're not immune to this labor crisis. They're not immune to the burnout. And the demand is so high for people needing help. As we see these increased rises of depression, anxiety, we need more access to counseling. How do we protect you? How do we protect the frontline workers from burnout? How do we close that gap and meet the demands of those who are asking for help, but also protecting the frontline workers?
Yeah, I think those are incredibly difficult questions as well, because we have colleagues that are working 60, 70-hour weeks, working 10 o'clock with a patient in crisis. Most of us that are in practice don't turn our phones off, which probably we should. So trying to balance a work and what we know about burnout and depression in our own professionals and provide the care. So I really think the boost in the care available, I really believe in leveraging technology, having team-based approaches to care, because I think too often the burden being on one clinician probably isn't a great thing. So I'm a firm believer in team-based approaches and finding the efficiency of finding the right professional for the right person when there's time. So clearly we need to educate and protect our frontline workers, be they mental health or otherwise health workers. But that's not going to necessarily address the gap. The gap has to be addressed with probably an increase in funding, but then finding an efficient way to use that funding, not just continue to throw resources at a problem that's struggling.
Thank you, Dr. Jetley. One of your sayings, I see one of our witnesses has their hand up.
Peter, did you want to add on to that question? Is that what it was? You wanted to add on to that? Okay.
Yes,
Michelle?
Madam Chair. I don't know if I just have a minute. I just found the question very interesting, and there's just this point about the burnout, because I think a lot of healthcare professionals, including myself, may have experienced some level of burnout in the past few years. But one thing, and I've thought about this quite well, and I was just listening to Dr. Rakesh when he talked about us not turning our phones off, which is what most people do. I just came back from vacation, and every time I'm on vacation, I find that my phone is constantly on, especially from colleagues who I'm looking after their kids. And I find that it causes a lot of stress. From like, it's easy to turn our notification that we're going to be away when it comes to email, but for phones, you can't do that. What I think we should really start talking to medical students, because there are a lot of mistakes that we made that we cannot, it's hard to undo now when it comes to boundaries. So for me, the big message is boundaries and learning from the onset about protecting one's, being mindful about those boundaries. Because for a lot of us, especially when I started, I was like, okay, other healthcare providers, you do anything to support your colleagues, but then when there are no boundaries, and then I find that there's that domino effect and we end up burning out, and it's hard to now tell the same people to say, please don't do this at this time. So I think at this point, that could be one of the things that we could look at, looking at medical students, that when they start, they shouldn't make some of the mistakes we made.
Perfect.
Thank you.
Michelle, we'll get you back to you for another round. Thank you so much. Anita, you have the floor for 6 minutes.
Yes, thank you very much, and thank you to all of our witnesses. My first couple of questions are for Ms. McNeil, specifically around newcomers and immigrants. One of the things that you mentioned is that there's various different stressors on immigrant women, some of them relating to things that they went through before they came to Canada. And we know that in many parts of the world where there's conflict or war, immigrant women, when they were in their home countries, were subject to rape as a weapon of war. And this sometimes doesn't come out until sometimes decades later, when they then start to talk about it for the first time. But at that point, they're here in Canada. Can you tell me what kind of supports, or if this is something you've seen in your practice, or what kind of supports might be available for those women, given that that's an experience that not many practitioners in Canada would have experience with or necessarily know how to handle those kinds of disclosures?
Yeah, I'd like to pass that over to Tanya, if that's okay.
Mm-hmm. Thank you, Karen. And that's such a great question. And as an organization that provides services to women with respects to employment and settlement and language services, it's something that typically does not get disclosed because there is, as mentioned in Karen's opening remarks, there is this strong stigma around they don't even know how to label what they are feeling. And so it doesn't get disclosed because they don't even know how to talk about it, because it's something that is just, it's to be kept hidden. And so there is intense shame that comes with that. And so it's not even considered a priority. So when they come to us with the, employment needs or language needs, all of that is just suppressed. And is typically not disclosed unless there is a strong rapport that is built between the client and their respective counselor or coach or employment coach. And so that's why at Achieve, we try very hard to instill the sense of the idea of wellness as beyond physical, and that is an important aspect of your life, and that it touches every aspect of your life. So if you want to be successful, integrating into the workforce, you have to look at that piece. But oftentimes it is not disclosed. And because we are not mental health service providers ourselves, and we're not experts in that arena, unfortunately, we rely on informed referrals for these women who might be in those situations.
Area of further study for our committee. The other question I have for you is around international students. You mentioned isolation, you mentioned, and I imagine during COVID probably even worse because also the limitations on travel. So I know that sometimes international students don't have access to the same kinds of counseling services that other students have access to. Is this something that you see as a gap? And what would you suggest that we do about that?
So at Achieve, anyway, we've seen firsthand the growing needs of the international students looking for access to free supports. And based on leads generated from our social media channels, specifically in 2 of our Brampton locations, about 42% of inquiries were from international students looking for help. Unfortunately, many of them are ineligible for a lot of the federally funded programs, as you're probably aware. We are encouraged by recent attention being given to these issues by Vice Chair and Brampton South MP Sonia Sidhu. We applaud Minister Sean Fraser for temporarily lifting the 20-hour per week rule for international students for work and recommend that this change be made permanent. And we also would like to see the federal government expand federal programs to include eligibility for international students to help support them, and including supports for mental health for women and girls.
Thank you, and I'm pleased to say that Sonia Sidhu is on our committee and is here today. So I appreciate my colleagues' action on that, and I think we could potentially take that as a recommendation from this study. My next question is actually to Ms. Boucher, and I just wanted to pick up on something you said that the UK Parliament was looking at, and that is the de-prescribing, so the withdrawal, because we heard in a previous testimony that often when young girls present at emergency, they're given medication and they're sent home, and then there's no follow-up. And some of this can be very difficult to withdraw from. And I just wondered if you said there were lessons to be learned there for Canada. Could you maybe, in a very short time, elaborate on what those lessons might be?
Oui, bien sûr.
Certainly. The committee in the UK was created to study addiction to prescription drugs and to see how to support people through withdrawal. Because what we've noticed in the community section is that there are a lot of young women and older women that are being prescribed antidepressants, but there are no follow-ups on the use of the medication, and there's no indication when to stop the medication. So these medications can be prescribed over years without there being a method for withdrawal or to stop taking the medication. It's also very rare for people to be informed about how difficult it can be to withdraw from these medications. So there's a deficit here in information when prescribing medication, and even healthcare professionals are not well aware of how, or cannot share the proper way of doing a withdrawal. What was studied in the UK is something that we could examine in Canada, yes.
Thank you so much, Anne-Marie. We're now going to turn it over for the next 6 minutes to Adrienne LaRoche. Adrienne, you have the floor.
Merci beaucoup, témoins.
Thank you to the witnesses for your testimonies today. There seems to be a trend here, the importance of working on the social determinants of life. What brings a woman to experiencing mental health issues? It is very interesting, and thank you to the witnesses for being with us. My first question is for Ms. Boucher. You talked about these stimulants, and you mentioned it at the end of your remarks. You talked about social determinants as well, and the Quebec model, and the independent community work, but there is an emergency, and community organizations do not lack projects or ideas, and you are a great example of this. One of the main problems is a lack of funding. Organizations are asking for a recurrent and stable funding from the government, and in order to respond to this need, the government of Quebec needs to increase its funds to the healthcare system. and your funding depends on that as well. Do you believe that the federal government needs to increase health transfers to the provinces without conditions? Answer. These health transfers are important in supporting organizations. There is an urgent need in Quebec, especially for mental health. And if I may, we want an increase in federal transfers, yes, but these transfers need to be done quickly without conditions. I used to work on homelessness, and I remember long negotiations on agreements between Canada and Quebec in order to combat homelessness, and funds were delayed even though they were urgently requested. So that would be the case with the health transfers. We hope that they would be increased and respect the jurisdiction of provinces, and it would allow us to do more community work on the field. You gave the example of homelessness, and to support women who are victims of violence, there was also an issue of delays throughout the pandemic. That's where we can see that the federal government creates overlap with efforts such as yours. You're requesting a stable funding without conditions, but this matter of overlap as well, because community organizations such as yours, you put a lot of time and energy into meeting the needs, but there's a lot of bureaucracy and funding per project. And can you tell us a bit more on the risks of this, of having funding by project, and how it cannot help you to support women in the long term? Answer. Funding by project can be useful in order to develop new ways of doing things, but for community groups and what we're doing in Quebec and elsewhere, well, we need funding for our mission, for our mandate. We need to support young people so that they can develop their own projects as well and test out initiatives. Often what happens with funding by project is that the funding is very limited and the modalities are imposed from the top down, and accountability is quite heavy and the bureaucracy is very heavy and takes a lot of our time. So we're hoping for public recurrent funding that would allow groups to stay independent and flexible so that they could develop projects according to the need. And currently, the request for services for young people is significant. And there are initiatives on this. And for funding by mission, this is something that you request from the Quebec government. So if the federal government imposes any terms, then that is something that has a negative impact on you, correct? Yes. So you need funding at the source. And for all the reasons that you mentioned, your community groups understand the realities on the field. You get to see what is happening in the different regions more directly. Yes, this is what we're negotiating. And there is funding from the federal government sometimes, but we want communities to be able to decide where this funding is allocated. When there's funding by project, well, what we hope is that communities can define the terms, but it's even better if we can just receive funding for our mandate that doesn't have conditions associated with it, so that we can develop solutions that the communities need.
Alors, j'aurai l'occasion.
I will hopefully come back on the issue with violence against women, but I think my 6 minutes is over, so I'll come back on my second round.
Thank you. I'm going to pass the floor over to Leah Gazan. Leah, 6 minutes.
Thank you so much, Chair. And my first questions are for the Northern Ontario School of Medicine. Diane Whitney or Peter Ajuze is, how do you pronounce your last name? Sorry, I want to make sure I'm pronouncing it correctly.
Ajueze.
Ajueze. Great,
Correct.
thank you. My first question, I mean, you spoke about in your presentation lack of access to care, but also impacts of colonization, mental health on particularly Indigenous women and girls, Two-Spirit people. We had a historic day today that actually unanimously passed a motion recognizing what happened as in residential schools as a genocide in the House of Commons today. And from your testimony, you see that those realities on the ground with the lack of resources. What changes do you think urgently need to be made to address the current crisis?
This question is what part of the current crisis, because there's so many, right? I mean, in talking about listening to people talk, why do medications get prescribed, particularly to young people that probably don't need the medication, is because there isn't any counseling, right? And that doesn't require me as a psychiatrist to do that. And I've been struck since I've been in the North. I've been in the North for 12 years. When I first arrived, I was getting referrals for grief. And I'm thinking, it's not a psychiatric issue. It's a family social issue. So the tremendous lack of counseling is very, very significant. But as Dr. Jetley says, we can't if we just keep doing the same thing we've been doing, which is doing one-on-one counseling weekly. The lineup just grows. So how do we offer things differently? I do mindfulness in my clinical practice, and I've been running a group for 10 years. When COVID hit, I reluctantly switched to Zoom. I had more people in the group, and they stayed longer in the group, and I was able to deliver it virtually. And it was an amazing experience.
So one of the programs they had many years ago in the Pasquiat Cree Nation in northern Manitoba, they would actually take families that were impacted by intergenerational trauma, having involvement in child welfare systems, and they would actually put them on an island as a family with a psychologist, an elder, and teach families how to be together as families and understand kind of, I guess, the historical trauma that was resulting in kind of the current struggles the family were having. And it was rooted in culture, a kind of outside of Western practices in terms of mental health care. Are you familiar with any kind of programs like that? And do you think those kinds of programs are critical, particularly when working with isolated communities, Indigenous communities?
I'm not aware in Northwest Ontario of any program like that, but I think it would be quite healing to for the family as a whole in relationship to the trauma experience. I mean, Peter, and you're part of the northern part of the province, Sudbury, any program like that for families or that exists?
Yeah, thank you, Dan. So not specifically about just general psychology or intergenerational trauma, but for substance use. So I am currently actually in Sault Ste. Marie attending a clinic for an Indigenous group. And I actually appreciate that question. And the answer to your question when you asked, do we think like using a culture-based approach would be helpful? Absolutely. So I have, since I started attending this clinic with this group, I have learned a lot about some of the Indigenous approaches, particularly towards trauma. And we have been incorporating it specifically in the clinic that I am working at. But I'm also aware of these, they call it like a land-based treatment, where it's in the in like where people struggling with addiction and substance use would go specifically for the Indigenous population. I've had a patient who attended and found it very helpful. I think they usually stay for about, I think at least a month to 3 months stay. So I've heard good. It's something that I think that a lot of physicians, even including myself, need to even learn more to see how we can incorporate it into our own practice as well.
Okay, thank you very much. Just going back to addiction, we know that for example, people that are using substances are often using substances to kind of self-medicate more complex mental health and trauma. Do you think the lack of available support exacerbates substance use in
So
remote
simple answer is
communities?
yes, significantly. And trying to find, particularly in the North, addiction treatment and treatment facilities that are able to manage patients with, I'll just use the term complexities, is almost next to impossible. Right?
Awesome.
And
Actually,
Sorry.
it's okay.
I was trying to get an extra 2 minutes.
I know,
Sorry.
you always push it. It's all good. It's all good. We're now going to go to our second round and switching to 5 minutes and then 2.5 minutes for Leah. And I'll remind Leah, 2.5 minutes for Leah. We'll start off with Anna Roberts for 5 minutes.
Thank you, Chair, and thank you to all the witnesses. This is a very difficult topic, but I have some questions for Dr. Jetley. Recently, I spoke to a family, an individual, a single mother now, who had a child with disabilities, both with autism and ADHD, and the child was given medication. I don't know what the exact numbers are, but I know there's a large number of divorce situations when a child with disability is born. And usually the mother ends up being the caregiver. In this particular situation, it's a culture thing. So the family, both families, felt that it was, I guess they wanted to blame someone, and they always blamed the woman. But nobody thinks about the single mom that's trying to take care of this child, and all she was advised was, suck it up, buttercup, and move on, and they provided her with medication. That wasn't the answer. She struggles each and every day, and she had to finally break down and basically put her child in a home because she felt that she was a threat to her child. Have you seen any situations of that magnitude? And if so, what can we do to recognize that, and how can we help them?
I mean, I think our colleagues have alluded to this. I mean, as a physician, I was a generalist. I was a family physician with the military. Then I became a super specialized guy. I became the trauma guy. But later in my career, I became much more of a generalist. And like what my colleagues are saying here, I agree in the sense that, there are determinants of health, and determinants of health are much more than health care. It's a societal thing. It's loving relationships, it's supports and things. So I do think that the answer to this one probably it's a tragic outcome of the woman not being able to take care, but overall the societal support or the cultural support has to be there. So sadly we do see cases like this, and I've had cases in my own practice like this as well. But I think, again, not to be the big bad psychiatrist, but medication may have been part of the answer for this child if there's a severe neurological disorder such as ADHD, but that's the beginning, not the end. Right. And I think, unfortunately, the emergency room analogy that one of our colleagues gave is prescribing that young woman benzodiazepines or something like that isn't the end of her story. It's the beginning. And I just think that a more holistic approach, looking at well-being, employment, stable housing, occupation, the mother probably needs respite, so you can't look after a sick child yourself all the time. So I just really think if we step back and look at what's really needed, because I think the Canada Health Act, which we can go on a whole other topic, isn't really a health act. It's to pay for medication if somebody steps out and they are never really accounted for mental health and psychology and social work and all the other paraprofessionals that we have. We have psychologists, we have chiropractors, we have physiotherapists that aren't covered by the Canada Health Act. They're all part of health. So I think that that's the issue here we're facing, is that the answer, that the magic bullet isn't the answer. The other answer is a much more complicated one, but we tend to kind of ignore it.
I guess what really boggled my mind, and I didn't understand this, so how the husband got away without paying for support and et cetera, and ended up leaving the country, and the poor woman tried to get a job to support the child. It caused trauma to her. And she didn't have the benefits to help the child or herself with therapy. So how can we ensure that this doesn't happen again? Because let's be honest, most women are the caregivers.
Yeah, I think part of, again, I mentioned earlier the advantage of team-based care, right? Back in the day, I know Diane has practiced for a long time as well, and I know her as a colleague, but when somebody was hospitalized years ago, they actually got treatment in the hospital. There were social workers there, occupational therapists were there, making sure they were safe, learning skills. Now you're hospitalized just to make sure you're not suicidal anymore, then you're discharged, right? So I think really the paraprofessionals will teach us psychiatrists a lot. They will teach the patients a lot. So really that team-based approach. There were centers throughout the place. There was George Hall Center in Toronto, for example, that's been around where you have the different professionals, social workers, occupational therapists, all of that can work with the parents and the children. So programs for a woman like this needs to be very, very family oriented, helping the mother and daughter or the mother and child communicate with each other.
Thank you.
And they're quite extensive.
Thank you so much,
But they
Dr.
used to
Jetley.
work.
I'm just going to now pass the floor over to Sonia Sidhu. Sonia, 5 minutes.
Thank you, Madam Chair. Thank you, all the witnesses joining us on this important study. My first question to Chief. Thank you, the tireless work you are doing on the ground in Brampton and across GTA. So my question is this. I know StatsCan has a report. Immigrant women have a fewer social connection than Canadian-born women. And in your experience, how newcomer women benefit from early integration? And I know when last time I visited there, you were talking about the career pathway program. Can you explain what was that and how a newcomer can get benefit from that early intervention?
Oh, Karen, yeah, sure. I'll address this one. So thank you so much for the question. The overarching issue with newcomer women and social isolation and social integration, I mean, we need to talk about the systemic racism that is entrenched in that aspect. So not only are they facing multiple barriers, not only are they incredibly stressed, and mental health is something that they cannot even talk about. They encounter, racism at every turn. And so the benefit of the early intervention with the social connections is so key, particularly when they are the backbone of their family. And they are the ones that are responsible for the taking care of the household, for the child rearing in most cases. In a lot of cases, particularly with some of our communities out in Peel, the families, newcomer families are in multi-generational homes. And so there is the added burden of senior care that comes with, being a woman, having to also take care of children. So what importance in that long queue of priorities the social connections take and reducing social isolation? At first glance, of course, they don't see it as such. Women put others' needs ahead of theirs. Newcomer women, particularly racialized or marginalized newcomer women, will place the needs of others ahead of theirs. But again, getting back to my earlier point about that wellness goes beyond physical, making sure that they're aware of that, making sure that there are resources available to them when they come and access our services. And that makes it okay. It's okay for you to think about yourself. It's okay for you to take some time to connect with other women or connect with other female professionals or female entrepreneurs. And it's okay to take care of yourself. And in fact, you need to take care of yourself in order to be the caregiver that is expected of you when you return home. So I'm not sure if that really answers your question, but that's certainly something that comes out a lot, and incorporating that into our services. So for example, the Career Pathways, a program that you mentioned earlier, we make it a point to have a meetup group every month where women can connect with other women like them, who perhaps look like them or have similar stories to them, where they talk about wellness and well-being, and can share stories and empower each other. So the Career Pathways program is about finding a job, but we make it a point to have those conversations and to be able to have the women have these conversations with each other.
Thank you. And we heard before then when newcomers women encounter discrimination, it creates significant psychological stress. Can you speak about the impact this can have and how we can make sure the supports are reaching those who need them? You talked about the stigma, you talk about the language barriers. How can achieve is making sure so the early support can reach out to them?
I think an important factor, excuse me, when you're looking at what programming is going to serve that community best is looking at the cultural appropriateness of such intervention. And I think if you're able to tap into that to get the buy-in from your end user, and in this case, it's the newcomer woman who, excuse me, if they feel comfortable and safe to talk about things that perhaps they're not able to talk about at home, and you do that from the get-go by making sure again that it speaks to the specific needs of a newcomer, marginalized, racialized woman. I think that.
Sorry, Tanya. Okay. Thank you so much. We're now actually going to head over to Andrea Laroche for 2.5 minutes. Adrienne?
Merci, Madame la Présidente.
Thank you, Madam Chair. I said that I wanted to continue my questions with Ms. Boucher, and you explained how you receive your funding from Quebec and how health transfers up to 35% without conditions would help you. You explained this well. But I would like to come back to the matter of violence against women or other factors and the importance of prevention. When we help community organizations or when we support social housing programs, because after the pandemic, as you explained, the mental health problems increased significantly, and now there's an inflation crisis and a crisis with the cost of living. So how can we help people, women and their mental health and their safety with social housing, for example? Answer. For example, violence against women in a family context. The lack of housing exacerbates this issue. It makes it very difficult for women to leave with their children. I don't know what the situation is throughout Canada, but in Quebec there is an unprecedented housing crisis. And we have a hard time building social housing. Costs have exploded and housing is not accessible. It is one of the determinants of mental health, and it has a significant impact. And for the prevention of violence against women and girls, it should be a priority when we're talking about women's mental health. I recently saw research that stated that in psychiatry, women who are hospitalized, well, there are 90% of them who had experienced abuse in childhood or in adolescence. So we have to talk about preventing violence, but we also need to support people who experience trauma. Services need to be adapted to that, need to listen and take into account their stories and not only see their anger or their suffering, and we can't only act on the symptoms. It needs to be easily accessible for women and girls. I'll have to come back on this, but this past weekend, there was a demonstration for violence against women.
Move over to Leah Gazan. Leah, 2.5 minutes.
Thank you so much. I just wanted to continue on with the Northern Ontario School of Medicine. So Call to Justice 3.4 of the National Inquiry into Missing and Murdered Indigenous Women and Girls called for, in quotes, all governments to ensure that all Indigenous communities receive immediate and necessary resources, including funding and support for the establishment of sustainable, permanent, no barrier, preventative, accessible, holistic wraparound services, including mobile trauma and addictions recovery teams. They go on to say, we further direct that trauma and addictions treatment programs be paired with other essential services such as mental health services and sexual exploitation and trafficking services as they relate to each individual case of First Nations, Inuit and Métis women, girls, and 2S LGBTQIA people. It's clear that's not happening from what you've shared. And part of the issue is the funding structures. We saw that with the Canadian Human Rights Tribunal ruling, where they said there was willful and reckless discrimination against First Nations children on reserve by not providing the same funding as kids residing off reserve. No reason. But we also see that in the healthcare system, different allocations of funding. Would you say that that is an example of systemic racism? Either one of you?
Certainly, yeah, I'll agree there. I mean, when something like that gets written, but then doesn't get implemented, so, and why is that, right? And there's examples in Northern Ontario of racism within the medical system, being honest about that. And another thing, just what I also done is I was the program director of the psychiatry residency program for the Northern Ontario School of Medicine, and I actually had some of my psychiatry residents expressing concern and frustration, and one of them actually finally made a complaint about the behavior of an emerged physician in a facility in Northern Ontario. So I mean, unfortunately, it's still there and it's still alive. It's nice to see the young doctors saying this isn't right, and I support that resident making that complaint. So
just
actually, we will make sure we get back to you, Leah.
Perfect.
Okay, so we're going to be
Thank
starting
you.
our third round, and we're going to pass the floor back over to Michelle Frey for 5 minutes.
Thank you, Madam Chair. And I'm going to go back to Dr. Jetley. I know you had started to finish something you were doing in your testimony, and I just wanted to give you the floor to finish that in terms of what you think we should be focusing on research and women.
Yeah. Oh, thank you very much for that. First of all, I completely agree with my colleagues that medicine isn't always the answer, but sometimes it is. So if we are going to medicate, we need to be careful to make sure that we are translating studies correctly. I mean, Peter, as our colleague, years ago, we used to think that children are just little men and women. And we used to give them medication based on weight, but then not understanding their liver and things. And years ago, we used to exclude women almost all the time because of menstruation, because of they might get pregnant, they might get things. So we had a very good justification for not including them because you couldn't control for a time of month and things like that. But then when the medications get released, we give the same medications to women as well, right? And so the problem ends up being when we include and we analyze by gender, we tend up not having enough money to have enough women, especially military veteran studies, and then you don't really report on them because they're not significant. So I think there have been laws passed in the U.S. The Revitalization Act in 1993, the NIH presented, but these things haven't really been followed. So in 2013, Ambien, which is like our Zopiclone, the FDA reduced the dose in half because they found out that women were clearing the medication less, which means they had a higher dose in the morning than they were supposed to be up. And guess what? That's when you're driving the kids to school. That's when you're getting breakfast. And so mom's kind of stoned in the morning. So I'm just thinking in terms of we have to kind of really look at making sure that the studies, we don't just GBA analyze and say, yes, we've considered it, but actually report on the differences because menopause happens, pregnancy happens, postpartum depression happens, menstruation happens, and that yucky biology does make studies harder, but then we end up applying the medications to those people. So I just think that that's really important for us to move forward. The funders can ask for it, but if we end up having 90 men and 10 women and our differences aren't statistically significant, it's not helpful. So that's kind of one of the points that I wanted to make just from a pure biological psychiatry perspective.
Thank you, Dr. Jetley.
The brain studies were the same way. We did right-handed men. because that was easier for brain studies.
Interesting. Thank you. Lots of information to dissect there. I'm hopefully going to get 2 more questions in here. I'm gonna direct this again to you, Dr. Jetley. We had a UNICEF report came out in 2020, and it is really shocking and upsetting. Canada ranked 35 out of 38 in top rich countries. I use air quotes there, like rich countries is their definition. And we were 35 out of 38 on their report card of highest rates of teen suicide. Why do you think we are getting so much worse when we're supposed to be this great country?
Well, I mean, I think it goes to going back to the whole holistic society thing, well-being, social supports, connectedness or disconnectedness of society. From a treatment perspective, when we have the lack of access to care, I mean, a lot of times social things, but there are kids that become depressed, that become psychotic. I mean, it's abysmal. I mean, in my city, Ottawa, it's a year and a half to wait for a psychiatrist for a teenager, right? And I mean, I have kids that age. A year and a half is a lifetime at that age, right? So I just think that, again, it's that need care gap, and so they'll go to the emergency room time and time again, and eventually they'll complete suicide. So I think it's the whole thing from the societal thing. We talked about bullying, we talked about these things, and safe place, raise help, care by the paraprofessionals. But then that acute suicidality needs sort of urgent psychiatric care sometimes, and we really don't have that. I mean, we can talk all about universal health care if we want, but the reality is it's abysmal how long kids have to wait, and that's why my colleagues are phoning me and asking me for help all the time.
It's true. Those are staggering statistics, and you said it really well. The other thing you said that I thought was really powerful was you said social media is traditional bullying on steroids. I have barely any time left, and I'm going to direct this to Dr. Peter Adjuze. I don't know if I've said your name right. When we talk about eating disorders, I'm curious if you believe that an eating disorder, if there's data or research to say that an eating disorder is a symptom of trauma.
You've got about 20 seconds, Doctor.
Okay. Well, okay. Definitely, there are connections between eating disorders and trauma. Specifically, I know eating disorder is a big umbrella term. We have anorexia, you have bulimia, you have binge eating disorder, you have avoidant restrictive food intake disorder.
I'm going to help you out, Peter, here. I'd say yes. And most patients with eating disorders have a history of trauma. Not all, but sort of like the numbers like borderline personality disorder, you're talking 80 to 90%.
Awesome. Thank you so much. I know we've got so much more information in all of your heads, so let's get as many questions in as we can. Passing it over to Mark Saray. Mark, 5 minutes.
Merci, Madame la Présidente.
Thank you, Madam Chair, and thank you to all the witnesses. I wish I could have more than 5 minutes to ask questions to all the witnesses. I'll start with Dr. Adjuze and Dr. Whitney. I think it's important to give context. When you talked about Northern Ontario, Dr. Whitney, you're in Thunder Bay, and Dr. Adjuze, you're in Sudbury. That's 11 hours to drive between the two. That's incredible. When we talk about duality in Canada, you cover about 90% of the geography of the province of Ontario, about 115 First Nations. The services are disproportionate from Toronto and other centres.
We're looking at $4.5 billion to negotiate with the province. Yes, the federal government has a role to play with the province, but I wanted to get your sense when we look at lack of training, lack of professionals, innovation, obviously the video conferencing that you're utilizing. What can you recommend here to the federal government for us to be negotiating with the province to ensure that we have the supports needed and the massive gap that you have to deal with? Dr. Whitney talked about bereavement leave, and it's just very difficult. So I'll start with you, Dr. Whitney, and then Dr. Adjuze could chime in to recommendations to the federal government.
I mean, one is supporting infrastructure, including internet access, because it's not outside of Thunder Bay and Sudbury. it's not that easily available. Number one, right? I mean, number two, I actually have a paper here. Somebody wants it, but it's actually from the Ontario Medical Association students who have solutions, including covering counseling for everyone that's universally covered, OHIP covered, whatever you want to call it, right? That people have access to appropriate counseling. And number three, on a positive note, having been the former program director for the psychiatry residency program at NOSM, I mean, we have now graduated 8 residents, 2 of which are Indigenous and practicing in the North. And out of those 8 residents, 6 are practicing in the North, and one of them is living in Northern Toronto, but does all her work remotely. So support the medical school, right? Because we're trying to do some really, I think, unique things, and we often attract people who finish medical school who are from the North, and those are the people who are staying in the North.
We have just 2 minutes left. Dr. Ajouzi, I'm sorry, Dr. Whitney, I know you have lots more to say, but I'm trying to get the time in.
Yeah, thank you, Honorable. One thing I wanted to just add, because you rightly said about the vast area in the North. From my experience working in England and in Ireland, they have a different model for mental health. They had let's say if we had 4 psychiatrists looking after a community, then that community would be divided into those sections, and each psychiatrist will have a team of multidisciplinary team, social workers, nurses, and it was easier to track, to be able to follow up with when patients with difficulties, and I feel that because of the uniqueness in the North, if that could be considered, whereby those models, whereby we would have teams of healthcare professionals looking at certain areas and making sure we don't miss any area, because it's good to have the Zoom and virtual care, but that is not adequate. It's not the same. I see it when I come in person versus when I do the Zoom. We have so many doctors from the United States and from down south who are able to provide these Zoom services and prescribe medication. But I think we need more. We need teams and people who know the community and can follow up with the patients and be able to, and I think that would be a better care. Thank you.
Thank you. I think I have 30 seconds left. I just wanted to mention that the Northern Ontario Medical School, thank you for what you do. Since 2015, you've added 838 medical professionals, 65 doctors are Indigenous, 171 Francophone. So I know you mentioned about infrastructure. So I just wanted to, to look at what better. I know the federal government has supported in 2005, and maybe just as a last note, I know the chair is looking at me right now, but to kind of, and I'll just on a personal note, something I haven't said in 20 years or I haven't said to anybody, but I just wanted to personally thank you, Dr. Ajouzi, for the support you provided me over 2 years, many moons ago. So I just wanted to say that, to thank you for what you do and for people and across Northern Ontario and across the country. And thank you for choosing Canada. Merci.
Thank you, sir.
Thank you very much, and thank you, Mark. Thanks. Absolutely. This time to get that opportunity to say thanks is sometimes when you have to do it, and I appreciate that. What I'm going to do is I've messed around with the schedule. Sorry about this, everybody. To Adrienne and Leah, I love when the clerk looks at me and thinks, what are you up to, Karen? I'm going to go 6 minutes, provide you an extra instead of going back into a round and having to cut you off. Continue at 6 minutes, 6 minutes. To Anna, 4 minutes. To Jenna, 4 minutes. To Emanuela, 4 minutes. And with the request as the chair, if I could have 3 to 4 minutes to ask some questions, if that's okay. Everybody's good with that? Okay. Except my own side. Okay, fantastic. So great. Okay, I'm going to pass it over to Adrienne. You have 6 minutes.
Merci, Madame la Présidente.
Thank you, Madam Chair. Thank you to the witnesses again for being with us today. And to start my final turn, I would like to come back with Ms. Boucher. During your remarks, you talked about social determinants, and you brought it up in your answers as well. So what I heard is that your groups need financial support. It is important to better pay staff as well. And there needs to be more investment in social housing. That is something that the federal government can do. It's something that we can examine. but also for violence against women. In Quebec, there was a very interesting report called Rebuilding Trust. A lot of recommendations were published with that report. Last Sunday, there was a protest. It had to do with men and e-bracelets and safety, and that their federal government aligns its strategies with Quebec to protect women, and how we can work on that social determinant that has an impact on mental health. So your question was, what exactly? I was saying that because you work in community organizations, you talked about violence against women and the importance of the federal government aligning its measures with Quebec to counter violence against women, and how can that help with their mental health? Supporting community organizations is important. There are women's rights groups and groups that support men as well, and all of these groups require support. So there is the importance of aligning efforts between the federal government and Quebec so that all of these groups can work on prevention and support the people who need it. And briefly, for the last issues that you mentioned, when we talk about medication and support for withdrawal, what do you expect from the federal government? Answer: we hope that studying addiction to medication and withdrawal support is something that the federal government could do. So they could have a study throughout Canada to see what practices are and make recommendations so that when a medication is prescribed, that people receive the proper information and that healthcare professionals be available to help people if they want to reduce their use of medication or to support them through withdrawal. Because spending in health means spending in medication as well. We need to see whether or not what is prescribed is actually useful for people, and withdrawal is very difficult. So, research with Health Canada, for example. Yes. I will stop my turn with Mr. Jetley. You mentioned something about bullying on social media, that social media increases the feeling of isolation, that there's a lot of bullying online. We saw all of these problems get exacerbated during the pandemic, and it had a significant impact on the mental health of women and girls. Would countering this online hate help, and would it support the mental health of young women and girls?
Yeah, I believe so. I don't have the answer for it, but I do believe that it exacerbates the anxiety. It exacerbates sometimes the loneliness and isolation. I mean, for example, when some of us were growing up, and if I did something embarrassing in class, 7 or 8 people that saw it might laugh at me and make me a bit embarrassed. But now, by the time I get home, it could be uploaded, and everybody in my class, everybody in my school, everybody in my town could see this. And that might affect me not going to school, and then my parents are going to take me to the doctor and wonder what's wrong with me. And so I do believe, I think there's lots and lots of positive with social media, don't get me wrong at all, but I do think it's very double-edged. So I do think it may involve, helping young girls and women to sort of separate the fantasy that is social media from that. I've got daughters that are exactly at that age, and every kid at that age wants to be a Kardashian and wants to be famous, and that's the world, unfortunately, that they live in. So I do believe it's a problem. I do believe there's many, many benefits from it, and if you are away, I mean, you can speak to your loved ones, halfway across the world, so that's fantastic. But you could also tease and bother them. So I do think that some education, if only they could just feel comfortable going to an adult, for example, and saying, this is difficult.
Monsieur
Jetley, beyond education, how could the federal government take on hate speech? Because social media is not a safe space. It has become a space where there is bullying and threats and violence. And our role in the federal government is to tackle this and to have legislation to counter this and to control hate comments.
We'll allow this question for about only a 15-second response. Dr. Jetley?
I'm stepping out of my expertise. I'm not a lawyer, but absolutely. I mean, if we're encouraging, if it's hate speech, we have legislation. Maybe some of this needs to be expanded to cover platforms so we keep up with the technology.
Perfect. Thank you so much. I'm now going to turn it over for 6 minutes to Leah. Leah?
Thank you so much. Chair, I want to go back to talking about the call for Justice 3.4. I've said, do you think one of the problems I asked was systemic racism? But I want to expand on that, because one of the things that was shared earlier on by Dr. Ajuzi is that people often have to leave their communities. I know that Dr. Whitney, you indicated, often experiencing systemic racism in hospitals. We know this exists, certainly in the city of Winnipeg. I have a picture, there's a picture of a fellow who literally died, an Indigenous man who literally died in the waiting room waiting for help because they thought he was intoxicated, and he literally died in his wheelchair. We hear stories about like this all the time. And I'm asking this because, people dealing with complex mental health have to go to places where they experience systemic racism. But compiled with that, they're now away from their loved ones and support systems. Can you explain how these disparities further exacerbate mental health issues?
Well, they do. In the way we've been talking about social determinants of health, of isolation from family and support, and COVID's exacerbated that even further. And at an awesome event recently, some patients shared their experience, Indigenous patients shared their experience of being in hospital during COVID, and it was actually quite frightening, right? My question is there a way to provide those patients some type of support in hospital from their own cultural point of view, from an elder or an advocate or whatever word you want to use, whether that would be helpful, and it'd have to be 24-hour, 24/7 support, because it can't just be Monday to Friday.
So building on that, that's wonderful, and I think we need that support and care in hospitals, absolutely. I want to go back to what my good colleague, MP Saray, was talking about, the importance of training so people can actually stay in their communities and get the help they need in the community. Would that be a better solution?
I mean, I can't disagree with that, but the challenge is in some of the really small communities, like my patient who is in a reserve of 30 people. I mean, right. But the question is, why can't we do it? I think, why can't we sort of have a hub and spoke type of approach to it? We have more than a hub of just Thunder Bay and Sudbury, because that's a long way for people to come, right? Can we not offer some basic services closer to home?
So more holistic mental health care rather than just in bigger urban centers.
That's right. And as my colleague, as Dr. Ajuzi has also talked about, is actually having a team. I'd love to have access to a psychologist, a social worker, an occupational therapist. I practice alone in the community by myself. Right? And I have residents, psychiatric residents, and just, my husband runs my office. But that's it. I don't have a social worker. I don't have an occupational therapist. And I really could, and it doesn't mean I have to have one full time. What I need is I need access to one. So I don't think that's just a northern issue. It's an organizational issue.
Yeah, and I think also a funding issue as well, I would argue. I have time for one more question, and I wanted to move on to Achieve. So many immigrants and refugees that come to Canada have trauma, sometimes have trauma and other complex mental health issues, PTSD, especially coming from places where maybe there's war, for example, and leaving situations of conflict. So in 2021, there was a report released in the International Journal of Environmental Research and Public Health, and it was titled Refugee Women with a History of Trauma, gender vulnerability in relation to post-traumatic stress disorder and this is what they found. It said, after a review of different studies, it seems clear that a higher predominance and severity of PTSD in refugee women is related to gender-based traumatic experiences, such as rape, sexual assault and abuse, or genital mutilation, among others. So people come here with diverse experience and often don't have care that they can access with people that actually understand their experiences. So in saying that, do you think that, I mean, it's clear that there's not enough culturally responsive and culturally safe trauma care. How do you think that needs to change immediately to ensure that immigrant and refugee women and girls receive the care mental health care that they receive, or that they require, sorry?
I'll let Tanya answer that too, but I just will say that there's also the language barrier. So many people have difficulty, not just culturally appropriate counseling and resources, but interpretation, translation, ideally with somebody who even comes from their own culture, background, or community and speaks their own language is really would be extremely important. But perhaps Tanya can add to that.
Thank you, Karen, for saying that. And actually, I've been thinking about my co-witness here, Ms. Boucher, on what she had said before about project-based funding. And I think your question is, what can we do to have this happen immediately? I think one of the things is to put less emphasis on project-based funding because it is quite restrictive, and you feel like just when you're about to have a breakthrough and you have some momentum, suddenly the rug is pulled out from underneath you.
Perfect.
You can no longer provide service.
Thank you so much, Tanya. That's fantastic. So now we're going to go into those 4 minutes. Anna, you've got the floor for 4 minutes.
Thank you. So this question is for Dr. If I mispronounce your name, I apologize. Is it Ajui? Did I say that right?
Ajuizi.
Ajuizi, I apologize. So you mentioned Ireland. My colleague, Michelle, shared with me the reference of the 3 top countries, and that was Netherlands, Denmark, and Norway. How can we learn from other countries on how we can develop the same programs here that would benefit our community?
Yeah, thank you, Honorable. So I've had the opportunity because I was born in Nigeria and I grew up. I did my medical school and then I moved to Ireland where I trained as a psychiatrist before moving to England and trained as a child psychiatrist and then moved to Canada. So I've had those opportunities to learn from the different countries and different practices. I must say that every country is unique in their approach with regards to mental health. And that's one of the first things I noticed when I came to Canada was like, okay, there was a different approach. It was more like a specialist, like we have different mental health professionals who would focus on an area of special interest, like, for example, mine, which is eating disorder, and we have people with addictions and different areas. Which is good in that way. But in those other countries, specifically Ireland, I found that the approach was different, and it had its own advantages when it comes to this team approach of having multidisciplinary, like social workers, nurses, who would know almost everybody in a community. So you have a team that's assigned to one community, would know when there's a family moving out, a new family moving in. And so it was easier to monitor. And we find that generally in Europe, you mentioned Netherlands. So that's why sometimes you see a lot of research. It's easier to be able to monitor and do longitudinal studies, even for 10 years, even when people move to a different province, because you have a team of healthcare professionals who are quite close to them, and they know, and the families are comfortable with the healthcare providers, and they know almost everybody. I don't know how practicable it is to be able to incorporate some of these models, but I think that it's definitely worth trying because there are a lot of advantages using that approach.
So one of the things that we heard in the budget was that the government promised $4.5 billion to mental health. I'm not sure where that money's gone yet, but what is the cost per capita? Would you know that information? Probably not. That other countries are spending compared to Canada.
No, unfortunately, I don't.
You don't know that.
I don't. Yeah, I don't.
I don't expect you to, because I guess I'm curious to say, how can we rank so poorly, being one of the richest countries, so they tell us, and yet, why can't we learn to better assist our own communities here in Canada from other countries? Because there's a lot of learning there to have, just like you explained to us of what's happening in Ireland. I mean, they've got a lot of rural areas, and so do we. And we're hearing today from different witnesses that the rural areas, they don't have internet, they don't have access to the infrastructure. So what is it that we can learn to implement those same procedures here in Canada?
You know what? That's a good question. I know one of your colleagues had mentioned about. That was the first time I'm hearing about it, like mobile services for the indigenous areas. I have been working in this community that I came to now for the past 3 years. I've never heard of anything like that. So I know somebody had asked, is this a form of institutional racism? I couldn't say that, but I think maybe starting with accountability about where always waste that money. And yeah.
Perfect. Thank you so much, Doctor. I'm now going to move over to Jenna for 4 minutes.
Struggle's real. Thank you very much, Chair. Thank you very much to all the witnesses for your testimony, but more importantly, for the work you do every day. I'd like to start or direct my first question to Dr. Jetley. You made the comment a few times that right now it's a year and a half or 18 months wait for someone to see a psychiatrist here in Ottawa. And in throughout this study and some of the testimony we've heard from other witnesses, when we've been talking about mental health and particularly relating to young women and girls, we've heard about the impact of psychotherapy. We've heard about how useful talk therapy has been for young women. As well as that peer-to-peer discussion and having peer support. And I'm wondering if you can speak to that.
No, thank you for that. No, I think those are good points. I think one of the things with the 18-month wait is we've got the psychiatrist and the Holy Grail. Like, you've got to get to see a psychiatrist and suffer until you get there. And the psychiatrist doesn't have all the answers. So I think the idea is to have more of a team-based care, exactly as Peter spoke to. But I think yes, it starts with the community, it starts with peer support, it starts with trusted adults, trusty peers, mentors, mentees that create this community where discussing how we feel has been normalized. That's something that we worked on in the military for 20 years. And if your colleagues know you when you're well, they'll notice that subtle change, right? And have the courage to say, go get help. I mean, so I think we've done a good thing that way. I think the lack, of course, is that we don't always have the help when people, and I've always looked at soldiers, veterans, children the same way. You have a window that's open, and that window is briefly open, and you need to sort of get the help quickly for that.
Incredible.
But I do believe it starts as a community. It's a community thing for sure.
Yeah. Wonderful. Thank you very much. And quickly just turning to Ms. Boucher, I was really struck by some of your testimony around the use of psychomedication and the medicalization of young people. And I'm wondering if you can expand upon that, and particularly any observations that you may have over time and through the pandemic, how this has perhaps changed or evolved one way or the other.
Ce qu'on a constaté.
Before the pandemic in Quebec, for example, in 2016, there was the Mouvement des Jeunes en Santé Mentale, and it was created after medicalization and issues faced by young people, and this focused on marginalized young people. And it stated that if there is a lack of support than often youth receive medication. And they were able to get data on this reality. So a young marginalized person with family issues or homelessness, well, this person is more likely to be medicated. And what we saw with the pandemic is that there was an increase in prescription medication for antidepressants or medication for ADHD. We're wondering how this might fill in a gap in services and support. A lot of people mentioned it today. It is hard to have access to support, and often the population doesn't know about other supports, for example, peer supports. And so psychological services are not necessarily accessible, and so the doctor will prescribe medication.
Back over to Emanuela Lampropoulos. Emanuela, you have 4 minutes.
Thank you, Madam Chair, and I'd like to begin by thanking our witnesses for being on the panel today, but also for the incredible work that you do in your communities and to help those in need. Of course, every single study, every single session that we've had with panelists has been very difficult to hear because we know to what extent Canadians are feeling the pressure right now and are experiencing mental health issues. I'm going to ask my first question to Dr. Whitney. You mentioned that there are twice the rate of suicidal hospitalizations in the North, that 78% of people experience childhood or adult trauma in the North. And so obviously the need is greatest there, yet there are fewer resources there than anywhere else. You also said that during the pandemic, things got a little bit better because you were able to speak to more than one person at a time. You did sessions, and so you were able to, within an hour, help heal up to 12 people. Or I don't know if you gave a number, but if that's what And but this obviously created a barrier to accessibility for a lot of people who don't have internet connection, and this is a really other big problem. So, can you speak to the importance of getting Canadians in the North connected, internet connectivity, and as well the infrastructures that need to be in place in order to get people from place to place quicker, in order to get these services faster if they're not going to be in their communities?
Well, certainly the internet service is essential. I mean, I'm not saying it, that's the answer totally for care, but it makes such a difference. And my group that I was describing, at least I was able to actually include some people from outside of Thunder Bay in the group rather than having to do it in my office. So I was a big proponent of using Zoom. I did not use much phone because then with Zoom you can see somebody. I can see what somebody's house looks like. Is it more messy? Is it not? Anyway, so you can do an evaluation on a person and their house, right? I'm passionate about that. The infrastructure, is multifaceted, right? The transportation to get people into a major center for the care they need directly, right? The transportation, the hotel costs are through the roof. Right now, I had a young woman come in with her mother, and I actually helped them around some ideas about hotel costs, right? And those practical kinds of things about getting people around in Northern Ontario is not easy. We're not talking small distances, as someone mentioned. So, and for the Indigenous patients, I mean, I'll be honest, sometimes the structure for them to access their benefits is very difficult, right? I can't remember what part because my administrator, i.e. husband, deals with it. But one of the Indigenous organization, we have to send a letter to the organization before they can book their travel. Like, that's crazy. Right? So there's a lot of very practical, as you can tell, practical day-to-day things that are barriers for patients getting care. And I worry about the patients who don't get to me. The other thing I do is I do work with a maternity center. And just a plug for this, because it's a nightmare trying to get an Indigenous young woman seen and follow through with appointments for various reasons, right? And then we're talking, the unborn child, the other children, the mother, right? And a lot of times they don't end up in my office after the initial assessment because there's no support to get them there. And then what are the barriers to get them there? It's significant, right? So, that work I'm passionate about.
And I guess that's what continues this cycle of intergenerational trauma, right? When the mother doesn't get the help that they need, and then it passes on from generation to generation. Karen, I'm going to let you go ahead.
Thanks so much. And honestly, I'm going to kind of build off a little bit of where Emanuela was there. So thank you, everybody, for giving me the opportunity. I'm actually going to take this to Dr. Jetley. I have your paperwork from earlier, and you were talking about mood and anxiety disorders that occur in women. And it's one of those things that I think, if only I knew. And as a 51-year-old woman, I'm reflecting to what it was like as a teenager and raising my own teenage girls and what that was like. And we talk about mood and anxiety disorders. We talk about hitting puberty. We talk about prenatal care, all of these different things. I do not think we're doing enough when it talks about the fact that women's hormones are going like this all of the time. We're up and down. What can we do, and what should we be doing to ensure that women and young girls are aware that this is actually normal and that we need to self-regulate ourselves?
Well, I mean, that's a great question, and thank you for that. I mean, I think part of it is to separate normal from disease. Having raised two girls, or continuing to raise, I guess you never stopped, two girls through this whole period. One's 20, one's 18. So, and that's the problem. We have these classifications of diseases where if you are a checkbox, you have these symptoms, then you've got a disease. But people are so different, right? We'll call depression, a 56-year-old postmenopausal woman that's sleeping 18 hours a day, eating carbohydrates, gaining weight, and a 19-year-old male student that's losing weight, can't sleep. We still call it the same disease and give them the same medication often, right? So we have to understand the differences and sort of individualize things. And I just think that, what is normal, what is not normal, and when it is a disease are almost three different categories. So I think that's really important. And I got to quickly jump in for my friend Peter there. The interesting with the Netherlands is that it's 0.05 the size of Ontario. Like the beauty of the Netherlands is every single soldier in their military is within 2 hours train ride of the Central Military Hospital. So this is the problem that we face, and I'm in the NATO group quite often. And so the Canadian solution is going to be different, and we can borrow and help. But it's just, if you think about a map, it's smaller than Southern Ontario.
Thank you very much. Today has been an absolutely fascinating panel. I think that if people actually watched our committee, in its own way, we're doing a little bit of counseling here because it's helping us understand how this all is going forward. So on behalf of the Status of Women Committee, I would really like to thank our panelists for being here with us today. Thank you for bringing your expertise and adding to this. If there's additional information that you have not submitted to committee, I will remind you to do so because I know that someone mentioned, hey, I'll just send that forward. Please do. All of this information is very, very helpful. I'm just going to remind the committee on November 1st, we would like all of your human trafficking and sexual exploitation. We would like all of those witnesses in. October 28th. That's tomorrow. I'm supposed to have those. What's oh goodness gracious? She just keeps me working. So we need to have all of our witnesses in by tomorrow. Golly gee. Okay. So what's that? Oh, and then the recommendations to remind everybody, everybody would have got their version 1 today of our study. Please review that. We would like to have recommendations, this is very important, by 3 p.m. next Friday for November the 4th. Recommendations for our study number 2. You've got I'm just study number 2 recommendations. Please send those into the clerk by 3 p.m. on Friday. Thanks. And I will today we're adjourned. Mark says yes, adjourned.